Percutaneous salvage of a precious hemodialysis access. Case report. Case summary. 51-year-old female. Hypertension on calcium channel blocker. End-stage renal disease on regular hemodialysis for 1 year. Left brachio-cephalic AV fistula constructed 1 year ago. Presenting with lost fistula thrill. Duplex revealed. Acute thrombotic occlusion of the venous limb of a left brachio-cephalic AV fistula in the arm. 2 tight stenoses in the cephalic vein, one at the mid-arm level and another at the cephalic arch. No suitable veins for new access in either upper extremity. These duplex images highlight the acute thrombus beyond a tight stenosis in the mid-arm cephalic vein. Plan and disposition. The intended procedure was left arm AV fistula declotting and balloon fistuloplasty. Left radial artery access. Under ultrasound guidance. Employing Seldinger technique. A 6 French radial sheath. A 21 gauge needle. And an 0.018-inch guide wire. Scout imaging did confirm the pre-intervention duplex findings. Entry into the AV fistula was carried out using coaxial 4 French Bernstein catheter and an 0.18-inch by 300 cm guide wire. Crossing of the lesions was then achieved by the command guide wire, carrying a 3 by 80 mm balloon catheter. Confirmation of intraluminal position of the wire balloon complex was possible using surface ultrasound. Predilatation and maceration of thrombi was performed through gradual balloon dilatations of the mid-arm lesion. Another dilatation was applied to the cephalic arch, using the 6 by 150 mm balloon. Due to repeated recoil of the mid-arm lesion, a 7 by 100 mm self-expanding stent was deployed and post-dilated using the 6 by 150 mm balloon at its nominal pressure. Control angiography revealed. Successful declotting of the fistula. Brisk diflow. Intraoperative palpation of fistula thrill. Duplex visualization of resolved lesions. Optimized volume flow 1466 ml per minute. This slide shows control fistulography of the mid-arm cephalic vein lesion after 3 balloon dilatations, still exhibiting recoil and at the same time, no thrill was palpable. Stenting and post-dilatation of the mid-arm cephalic vein lesion could correct the recoil and was accompanied by instant palpation of fistula thrill. Post-intervention surveillance at 1 week revealed a patent, well-functioning fistula, with adequate volume flow and no outflow obstruction. The first hemodialysis session was completed for 4 hours from the fistula on the 7th day post-intervention. Discussion. Surgical declotting. Palmer et al. Reported technical success in 7 out of 10 patients with thrombosed autogenous accesses treated with an open, surgical approach. 6-month primary and secondary patency rates were only 51% and 69%, respectively. Surgical declotting didn't address occlusion etiology. Percutaneous declotting. It was first described in 1984 by Glanz et al. It can employ different thrombus removal techniques like maceration, lysis and aspiration. It can avoid surgical trauma to the vein as well as the known surgical complications. Can effectively address the occlusion etiology. Percutaneous declotting also avoids central venous catheters and their consequences. It also avoids waiting for maturation of a new access. Overall maturation rate is approximately 50%. Patency data are still under evaluation. Repeatability and minimally invasive nature still make it a priority. The message to take home is, percutaneous access salvage should be the #1 priority, being associated with better patient well-being and quality of life, compared with surgical declotting. Thank you for your attention.